Hey Chibis, I'm Ivy, and today we are talking about the hidden vascular and neuromuscular mechanics that govern male sexual performance. If you enjoy stories like this, hit the like button and subscribe if you haven't already. Let's go! The microvessels of the male reproductive system are among the narrowest in the human body, measuring a fraction of a millimeter in diameter. Because of their delicate size, they act as an exquisitely sensitive early barometer for total systemic health. Yet every day, millions of young men attributing sexual performance difficulties to low testosterone are seeking hormonal solutions for what is actually a combination of vascular mechanics, neuromuscular habits, and autonomic nervous system conditioning. If you have experienced erectile inconsistency or rapid ejaculatory latency, you have likely encountered a sea of aggressive marketing selling quick pharmaceutical fixes, unverified herbal supplements, and anxiety-inducing claims about modern endocrine collapse. This documentary will deconstruct the physiological reality of the male sexual reflex. By examining peer-reviewed clinical trials in vascular hemodynamics, pelvic-floor physical therapy, and neuroplastic tactile adaptation, we will reveal how targeted physical retraining can restore sexual function from the ground up without relying on commercial panaceas. The central question is straightforward. If primary hormonal deficiencies account for only a small fraction of sexual dysfunction in men under 40, what are the precise biomechanical and neurological systems governing performance, and how can they be systematically rehabilitated? Act 1. The endocrine misconception. In modern health culture, serum testosterone has become the universal scapegoat for nearly every male physical complaint. When an individual experiences difficulty achieving or maintaining rigidity, the immediate assumption is often that his hormonal profile has collapsed. However, clinical urology paints a dramatically different picture. Epidemiological data indicates that primary hypogonadism, clinically defined as total serum testosterone falling below 300 nanograms per deciliter alongside corresponding symptoms, accounts for only between 5 and 20% of primary erectile dysfunction cases. While adequate testosterone is necessary to support baseline sexual desire and maintain healthy tissue tone, an erection is fundamentally a hydraulic event, not a purely hormonal one. Furthermore, when circulating androgens do decline, the underlying cause is frequently metabolic rather than testicular. Adipose tissue contains aromatase enzyme, which actively converts circulating androgens into estrogens. Elevated body fat directly alters systemic sex-steroid ratios while simultaneously promoting systemic inflammation that damages delicate endothelial walls. Treating this cascade with synthetic hormones without addressing body composition and vascular tone misses the primary physiological driver entirely. Act 2. Hemodynamics and the vascular engine. To understand how sexual stamina and rigidity operate, we must examine the vascular hydraulics of the corpora cavernosa. In an unaroused state, smooth muscle tissues within the penile arterial beds remain constricted under the influence of the sympathetic nervous system, allowing only a minimal baseline flow of oxygenated blood. Upon sexual arousal, non-adrenergic non-cholinergic neural pathways stimulate endothelial cells to synthesize and release nitric oxide. This signaling gas diffuses into adjacent vascular smooth muscle, triggering an enzymatic cascade that produces cyclic guanosine monophosphate. This chemical messenger commands the arterial walls to relax, widening the inflow channels and increasing arterial blood flow by several 100%. As these cavernous spaces rapidly engorge with blood, they expand outward against the rigid, non-elastic outer sheath known as the tunica albuginea. This mechanical expansion pinches shut the subtunical venules, trapping the blood inside the organ. This veno-occlusive mechanism is what produces and sustains full rigidity. If the endothelium is damaged by sedentary living, metabolic dysfunction, or chronic stress, nitric oxide production falters, the inflow is insufficient, and a venous exit cannot be fully occluded. This is why structured cardiovascular conditioning and compound resistance training serve as primary non-pharmacological interventions. Engaging the largest muscle groups of the lower body, such as the quadriceps, hamstrings, and gluteal complex, stimulates systemic blood flow, enhances insulin sensitivity, and upregulates endothelial nitric oxide synthase across the entire arterial tree. The reproductive vasculature does not operate in isolation. It reflects the functional health of your entire cardiovascular system. Act 3. The neuromuscular flow and somatic control. While vascular hemodynamics supply the internal fluid pressure, the voluntary and involuntary skeletal muscles of the pelvic floor provide the structural scaffolding that locks the pressure in place and modulates the timing of ejaculation. Two primary muscles govern this region, the ischiocavernosus, which surrounds the base of the cavernous bodies, and the bulbospongiosus, which encircles the base of the corpus spongiosum and the urethra. When the ischiocavernosus contracts, it compresses the proximal roots of the erectile tissue, generating intracavernous pressures that temporarily exceed systolic blood pressure, creating maximal rigidity. Simultaneously, the bulbospongiosus regulates pressure along the urethral tract. In landmark randomized controlled trials led by researchers including Grace Dorey, structured pelvic floor muscle training demonstrated extraordinary therapeutic efficacy. In these clinical trials, men with long-standing erectile dysfunction followed a 3 to 6 months protocol of targeted physical therapist-guided contractions. Approximately 40% of participants experienced complete resolution of their symptoms, while an additional 35% achieved significant clinical improvement, outcomes directly comparable to standard pharmaceutical interventions. Beyond maintaining rigidity, voluntary control over the pelvic floor alters the ejaculatory reflex arc. Orgasm and ejaculation are distinct neurobiological events. Orgasm is a cerebral and sensory processing event in the central nervous system, whereas ejaculation is a two-phase reflex consisting of emission, mediated by the sympathetic nervous system, and expulsion, driven by somatic motor neurons. By developing refined neuromuscular awareness, a man can isolate and engage the pelvic floor muscles without tensing his gluteal muscles or holding his breath, effectively modulating urethral pressure before reaching the threshold of ejaculatory inevitability. A critical clinical caveat must be emphasized here. Pelvic floor rehabilitation is not simply about aggressive clenching. While strengthening helps an underactive or hypotonic pelvic floor, many young men suffering from chronic anxiety or intense physical strain develop an overactive or hypotonic pelvic floor. In a hypertonic state, the muscles remain perpetually clenched and exhausted, which exacerbates premature ejaculation and pelvic discomfort. True physical retraining requires learning both maximal contraction and complete diaphragmatic muscular relaxation. Act 4. Behavioral conditioning and tactile desensitization. Physical hardware represents only one half of the equation. The other half is neural habituation. The human nervous system is exceptionally neuroplastic, constantly adapting its sensitivity thresholds based on repetitive sensory inputs. Over the past 2 decades, changes in solitary sexual habits have introduced unprecedented mechanical conditions. Habitual masturbation often involves rapid manual friction, high mechanical pressure, and minimal lubrication, frequently executed quickly under conditions of secrecy or haste. Over thousands of repetitions, the peripheral sensory receptors and the spinal cord adapt to this specific mechanical profile, establishing high tactile thresholds for arousal and reflex triggering. When an individual accustomed to high-pressure manual friction transitions to partnered intercourse, the physiological stimulation provides a markedly lower mechanical force distributed across a broader surface area with natural moisture. The habituated nervous system may register this natural input as insufficient, leading either to sudden loss of rigidity due to sensory drop-off or, paradoxically, rapid ejaculation driven by cognitive panic when sensations do not match established neurochemical expectations. Reversing this tactile habituation requires deliberate stimulus recalibration. Over a period ranging from several weeks to months, an individual can systematically retrain his neural pathways by reducing manual grip intensity, incorporating proper lubrication, and slowing the cadence of stimulation. This intentional downshifting allows the peripheral mechanoreceptors in the genital epithelium to regain baseline sensitivity to subtler, physiologically realistic stimuli. Act 5. The autonomic interface and cognitive arousal. Even the most robust vascular system and well-conditioned pelvic musculature can be completely overridden by a single burst of psychological stress. This occurs because the sexual response is governed by a delicate balance between the two branches of the autonomic nervous system. The physiological rule of sexual function is governed by an autonomic division of labor. The parasympathetic nervous system manages vascular dilation and erection, while the sympathetic nervous system triggers the ejaculatory sequence and subsequent detumescence. In simple terms, arousal and blood accumulation require a state of physiological calm and security. When a man experiences performance anxiety, fear of failure, or hypervigilant self-monitoring, his brain interprets the situation as a threat. The hypothalamic pituitary adrenal axis activates, flooding the bloodstream with epinephrine and norepinephrine. These stress hormones immediately bind to alpha-adrenergic receptors on the penile arteries, forcing them to constrict. At the same moment, the surge in sympathetic tone lowers the threshold for the ejaculatory reflex, creating the exact combination most men dread, loss of hardness paired with rapid climax. To counter this autonomic mismatch, cognitive and somatic grounding techniques must be integrated with physical training. Counterintuitively, attempting to suppress arousal by aggressive mental distraction, such as doing complex arithmetic or focusing on work stress, often increases background sympathetic tone. In contrast, deep somatic awareness, rhythmic diaphragmatic respiration, and pacing movements allow parasympathetic dominance to persist. Furthermore, resetting cultural expectations is essential for reducing this performance anxiety. Large-scale observational studies across multiple countries, notably those conducted by Marcel Waldinger, reveal that the median normative intravaginal ejaculatory latency time in healthy populations is roughly 5.4 minutes, with the vast majority of natural encounters falling between 3 and 7 minutes. Deconstructing unrealistic expectations eliminates the artificial panic that so often sabotages autonomic stability. Act 6. Biopsychosocial synthesis and long-term recovery. True sexual stamina and erectile stability cannot be achieved by isolating any single variable. The human sexual response is a biopsychosocial continuum, an intricate interplay where vascular capacity, neuromuscular control, behavioral conditioning, and cognitive calm must operate in complete synchronization. When you enhance your cardiovascular baseline through large muscle resistance training and aerobic conditioning, you build the vascular engine necessary for reliable nitric oxide production. When you cultivate pelvic floor awareness, you acquire the structural brakes and stabilizers to sustain intracavernous pressure and govern the ejaculatory threshold. When you recalibrate your tactile habits, you align your sensory receptors with physiological reality. And when you master autonomic regulation, you protect that physiological engine from the sabotaging effects of performance anxiety. Sustainable physiological adaptation does not occur overnight. While neuroplastic and vascular recalibration begins within the first few weeks, durable remodeling of vascular endothelium and pelvic muscle fibers typically requires 3 to 6 months of consistent practice. Approaching this process with clinical patience and structured methodology replaces shame with biological agency. If you are experiencing persistent difficulties, consider consulting a qualified urologist, pelvic floor physical therapist, or certified sexual health professional to establish a comprehensive, individualized diagnostic evaluation. Understanding your biology is the first step toward reclaiming total systemic health.